I'm in search of conversation guests. If you are interested or know someone that might be interested, please contact me directly. Thank you. Dr. Karl Burris, and I had too much fun talking. I forgot to ask him to plug his company, so I'm going to do that for him now. Karl is a doctor of physical therapy and a board-certified orthopedic clinical specialist. His company is Life Physiotherapy. They do mobile services in East County, San Diego, and online services throughout California. His website is livelifephysio.com. That's LIVELIFEPHYSIO.com. The phone number is 619-800-8173. Once again, that's 619-800-8173. The email address is karl@livelifephysio.com. That's KARL@livelifephysio.com. Hey, Dr. Burris, welcome. How's your morning so far?
Yeah, I woke up feeling fairly good this morning. I got my second dose of the COVID vaccine on Monday.
Yeah.
I woke up a little foggy headed, so kind of worked through that yesterday and feeling back to full strength today.
Oh, nice. So you got your first shot like probably a week or two ago?
I think it was about 3 weeks ago.
And then I think from 3 weeks ago, from at least the articles I've read, that the second dose is a bit stronger. So did you feel foggy on the first shot?
The first one, I just woke up with a little bit of a headache and probably a little bit more tired than usual, but a lot can factor into that. So, but yeah, I heard that the second one was a little bit worse. I actually woke up without a headache, and we're getting solar on our house, and I forgot about the appointment at 7 o'clock in the morning. So I slept through my alarm, and then this guy's knocking at the door at 7 o'clock in the morning. And I woke up, and it took a while, but I was like, oh, I feel pretty good. I don't have a headache or anything. But then I do a balance class at one of the senior living facilities. And when I got there, I was like, maybe I don't feel exactly perfect, but I was able to get through it. And the rest of my day was pretty light. So,
yeah. Is the COVID vaccine, the availability for it, like say, did your wife get a shot, or is it, are you able to get in line for it?
Yeah, so I was in a really good place. I work part-time at a living facility, and they have, because of the demographics, they have pharmacists coming to their facility. So I could just fill out the paperwork, give it to them. They're coming on these days. You're scheduled, and you already have the second one. I mean, they already have the second batch, ready and coming to them. My wife signed up. She's an audiologist with the school district, so she falls under that first tier, whatever tier and number we're in. And so she signed up on the first day and went and got her first one at Petco. But it seems like it's a little bit harder to schedule right now, especially the first one. If you get the first one, they're not letting you schedule for the second one. And so I think she did it where she was able to schedule for the second one. We got our first one on the same day, but she got the Moderna one, which there's an extra week between the first and second dose. So she gets her second one next week. So.
I read some article in San Diego at the Petco. All I remember from the article was something like 16 staff members got pretty ill or something, heavily ill from the vaccine. Did you happen to hear about that?
Yeah, I think it was just 6 people that had gone through the line, because you have to wait. So after I got my shot, I just had to sit in a chair for 15 minutes. But the drive-through ones, you have to go park and wait there to make sure you don't have a crazy reaction to it. And I think they said that all of them turned out to be fine, but they did need some medical attention, whatever that means. But they threw out that batch just to make sure. I think with keeping it super cold, it's a little bit, I don't know, it's a little iffy.
Yeah.
But
Gotcha.
you could see how something like that could happen for sure.
Yeah. Any current events that on your mind at all? Like for me, GameStop. That's a pretty fun topic.
Yeah, I just got into, I guess my, other than just putting money into a 401k or a Roth, I bought some cryptocurrency. One of my clients in
Oh, speaking of
Arizona,
my heart.
yeah, well, maybe you could give me some tips on it. I had a client in Arizona when I was practicing out there, and he was into a bunch of, buying, selling, trading, all that kind of stuff. But he basically dropped everything and just focused on cryptocurrency. And he would be, what do you call him? He was like a day
Day
trader
trader?
of
Yeah.
cryptocurrency, and he was making like money. And so he told me about one, and this was like right towards the end of the peak a few years ago, when it all came kind of coming back down. But he told me about this one, and I was like, I'm gonna buy that one. So I bought some regular Bitcoin, and then, or no, what's the main one called? Bitcoin, right?
Bitcoin, yeah.
Yeah, Bitcoin, and then some Ethereum, and then some of this other lesser known one that he kind of said was going to be like the major one. So I did it, and I left it there, and now it's probably made a little bit of money from where I put it. But I finally made a brokerage account and started getting into trading, and we bought some Tesla stock a little
Nice.
while ago. So we've just kind of been watching that grow.
Yeah.
I have not been able to get into really understanding GameStop. My cousin posted something on Facebook. He's all on it. He was all over Tesla too, and he was like, "Oh my gosh, this is taking off." And but it's kind of weird. It's kind of a weird, thing going on.
Yeah, GameStop, it's not an, what's the word I want to say? It's not for investing. Right now it's not for investing. So what happened this is what I understand, and I could be wrong, and I'm not a financial advisor. I'm a stupid dumb shit. So GameStop, there was about a year ago, someone discovered there was a lot of short buys against GameStop, and they're looking at the numbers, and they found out that it was just such a huge number where this hedge fund was putting in so many short buys that basically wanted GameStop to go out of business. And this is a morality philosophy type of theory with all this. It's not good to bet against companies morally, because if you have enough money as a hedge fund, you are filling out you are pushing a self-fulfilling prophecy. And if you're betting against American companies and you're an American, that doesn't seem morally right. Now, I totally understand people can you could look at a company, and if you have an educated guess, then you should be able to bet against it. I totally understand that. I don't know where the morality is exactly green or red and then gray.
Right.
So when these people on Reddit found out that this company was having such huge shorts, but if I understand correctly, they saw that the shorts were so much, I don't understand this. They're saying over 100% that they're shorting the company. So when you push over 100%, then the Redditor is like, well, even if we buy a little bit, we win, because they're going to have to buy back. They're going to have to buy back from when they short, they have to buy eventually to cover it. So the Redditor is like, well, it's 100% for them. So then it started a morality thing, I think, where people are like, wait, this is the one case where the common people could use the internet and say, hey, fuck you, hedge fund managers. You guys are doing this way too immorally. There's the gray where they're kind of immoral already at times, but this was too far, and people wanted to take advantage of that and voice with their dollar. So I think that's a beautiful thing. It is a risky thing.
Yeah.
It is. I think the hedge fund managers probably even if something bad were to happen, they'll lose a few million or a few billion, but that's probably going to be a fraction of their worth. So,
Right.
and even then, maybe a few people lose their jobs, and then they'll probably find another company and they'll make a bunch of money. So that's the sad thing about the situation. And then this whole thing should also make a bunch of other people question what the stock market really is and what is it doing. It's starting to become too abstractly immoral. I understand there's a lot of good behind it. Like companies could, if GameStop right now, if they were to use this opportunity, maybe do a pivot into mobile gaming or mobile game sales or something instead of physical places. I don't know if that would really work, but that's something where stocks, because if their stock value's up, they could ask for loans and stuff.
Right.
So yeah, I bought some GameStop, and I realize it's closer to stupid, and it's very risky and not very smart at times, but I'm for the morality of it. I threw in money that I'm able to lose. I'm not hoping to make a gain on this. I hope to make a gain, but realistically, I don't think I'm gonna gain on this. And I'm okay with that. I'm okay losing money and just saying, I'm for this cause. I'm for that cause, meaning there might be other millions that have their own spin on it, but that's my spin on it. And that's why I'm in on it.
That's
So,
cool. I
yeah,
didn't know that much about it.
yeah. So let's go do what you do. So you're a doctor in orthopedics. Do you focus mainly on, that's your degree? Is that correct?
So the doctorate is in physical therapy,
Oh,
and
that's right.
then after you do just like a physician kind of, they usually go into a residency program. Physical therapy is starting to go that route. So most people graduate and they don't go through a residency. You just are a general practitioner, and usually wherever you go, you're going to learn. You're going to keep learning how to be a good physical therapist and continue to learn throughout your career, hopefully. But the residency is an extra year, and you're practicing just like you would normally, but you have a mentor on site, and then you have residency communication with your other cohort and with the people from the residency faculty members.
When you say a majority don't do the residency, so do they stay as a physical trainer and don't become a physician at that point?
So I'm not a physician.
Oh,
The a lot of medical professionals have elevated their level of education. So like when I worked at a pharmacy, they were doing the transition from like the people that had been there for a while just had a bachelor's degree, and then some people had a master's, and then you shift to a doctorate. So some people had a PharmD, which is a doctorate in pharmacy. So the same thing with physical therapy and with audiology, like my wife. The bachelor's degree, there's great, fantastic physical therapists out there because they've been practicing for so long and have that real world experience that their title is a bachelor's degree. You still call them a physical therapist. And then masters, there's a few people that have master's degrees. Right now, any physical therapy school you go to in the United States is a doctorate. And that kind of transitioned. I remember when I was applying, Long Beach, because it was a state school, still offered a master's, but they were thinking of going to a doctorate. And now you can't be a physical therapy school if you aren't a doctorate. So they're still a doctorate of physical therapy, just like I am, but the specialty isn't. They don't have the official specialty.
gotcha. On the daily, what's your most common issue you deal with?
Oh man. So I've kind of taken. So it used to be there. Obviously, a lot of low back pain, shoulders, knees, anything that comes into an outpatient orthopedic clinic. So a lot of people are post-surgical. They just had a rotator cuff repair. They just had a hip replacement, knee replacement. But then you get the people that are going to physical therapy before they go that route. So, they have low back pain and they're trying to avoid surgery. I worked at a clinic that had a pool, so we did aquatic therapy. But pretty much anything that you can imagine, we could span the age range from, teenager sports injury to, 80-year-old with low back pain. What I've kind of pivoted towards now is working with primarily the older population, and fall risk has been a big thing for me. And I've also pivoted from doing, traditional physical therapy. You're looking at maybe like 6 weeks of care, and anything over that is considered, can be considered, like you're over treating. But what I found is there's a lot of people that, because of an ache or a pain that they've had for years, they've stopped doing a lot of things in their life. And so I don't think 6 weeks is really a good amount of time to really get them back on the horse of changing their lifestyle and really achieving the goals that they really might not even see for themselves because they see it as such a pipe dream. So when I go into an eval now, it's, I try to get those 3 to 6 weeks because, insurance wants to see what goals you have. But a lot of times the aim is to transition them to coaching. So I'm also asking, I don't just care about where you want to be in 6 weeks, but what about a year from now? What about 2 years from now? Where do you want to be? So,
Yeah. When you say the fall risk, is that a kind way of just saying elderly people are just falling a lot?
yeah. So fall balance is very interesting. It's a very interesting dynamic in our society because people just kind of assume that as I get older, my balance is going to suck. And so having a fear of falling is actually a self-fulfilling prophecy a lot of times, because if you
Okay.
have someone that's kind of like hesitant, like think about it, when we're kids, we're playing and running and cutting and jumping and doing all those things. And so we're constantly challenging our three balance systems, our vision, our vestibular system, and our proprioception, which is like how our joints and body limbs tell our brain where it is in space. And as we get older, that kind of decreases, right? I mean, you might go from playing sports to, having kids and having a job. And are you sitting down all the time when you're at your job? Well, when you're 20, 30, 40, you don't notice a big enough difference in your balance, right? And then, 60s, 70s, 80s hit, and you're just like, oh, this is what's supposed to happen, right? I have wrinkles on my face. I have aches and pains. I have all these medical conditions, and balance is just one of those things. But once you kind of start going down that path, by the time you're 70, 80, it's kind of, you can make huge changes and huge improvements. But, if you address it when you're 40, 50, and you just stay active and you keep doing things, then that fear of falling gets pushed back, like way far back. Once you have that fear of falling, then you sit down more. And we're so good. I mean, our TVs are 85 inches and we can just sit there and watch TV. And if you're living, especially if you're living at a senior facility, huge benefit. In a lot of ways, you have people that check on you. You have all of these amenities. You don't have to go anywhere for any of this other stuff. But a lot of times you don't even have a kitchen. So, they're bringing you food, especially during COVID. They have, dining rooms that no one can use right now. So you're not even walking to the dining room and back. They're bringing you the food in your room, and your activity just, goes even lower. So the more you sit, the less you're challenging those systems that maintain your balance. But you still feel like, well, I should be able to get up and go to the bathroom. Like I have to do that. I have to go in and go to bed, right? So it becomes much more dangerous and much more risky to do those things. because you are doing the opposite of what you should be doing, right?
Wow.
So then in our medical system, like I took my grandma to the doctor a while ago, and she has hip replacement, knee replacement, and then she fell and broke her femur right under where the rod goes for the hip replacement. And so typically what they might do for a broken hip or a broken femur is put a rod in, but there was already a rod for the hip replacement. And so they basically, like, you look at the x-ray and it looks like chicken wire. It's just wrapped
Oh,
around her
wow.
leg. So she's pretty good now, but her gait, her walking is still a little weird, and her balance isn't what it should be. And there's probably one leg that's a little shorter than the other. And when we went to the doctor, you know, they went through a lot of stuff. Like, there's a lot of stuff you got to pack into a short amount of time when you go to the doctor. But her one thing was she told the doctor that she didn't feel like her balance was very good. And like, he didn't even ask her to get up. He never watched her walk. He never watched her stand. He didn't see what was going on. All he said was, oh, well, you know, maybe some physical therapy or something like that. So people are, which is fine. That's not their specialty. That's not what they're there for.
Yeah.
But people kind of have the assumption that if you go to your doctor and you say out loud, my balance is bad, and they don't do anything about it, then that's it. That's the medical professional saying this is what you should do, right? And so there's so much that can be done for balance. So now I'm grateful that I get to go to my grandma and grandpa's living facility and do some balance and strengthening classes, and then I get to, you know, hang out with them a little bit, especially because COVID, no one's allowed in. So I get kind of a pass because I'm a medical professional providing a service. So I get to kind of go and see them too. But yeah, that's kind of one of my biggest things. And you know, you hear people once you start aging a little bit, everyone says, gosh, if you fall and break your hip, you're done. Right. And I've treated many people in a skilled nursing facility where they fell and broke their hip and they can't have surgery. And so they're literally just laying there in bed, and there's nothing else they can do. They certainly can't weight bear. Like, their femur is literally not able to bear any weight. Like, their leg would just slide up on their pelvis. So
Whoa.
it can be a pretty devastating thing. But getting to people early enough and, you know, convincing them that this is important for not just now, but 10, 20, 30 years from now is kind of my goal.
Yeah. Is there anything in the age group of 30 to 40 or 20 to 30 that you see that's a common problem, and anything that they could do to prevent what you're saying, which I'm assuming just stay active. But do you see a common issue from 20 to 40 or 20 to 30, 30 to 40, those age groups?
Yeah, I think something that I've certainly learned when I was in PT school, I realized, you know, every once in a while I'd get this pain in my back that kind of spread up my neck. And it was never really in my conscience before PT school. And then in PT school, I realized, man, every time I sit, I'm like, you know, I'm sitting like this and I'm looking up, and I already kind of have more of a curve in my upper back. And then when I got stressed for a test or something like that, then I was like really crouching down, and that's when I would get that pain. And so I became much more mindful of my body through PT school. And so just a 20, 30, 40-year-old, as being as mindful of yourself as you can, of your body. Something that I work with people with chronic pain is a lot of mindfulness, because they feel like the pain is happening to them and they don't have any control over it. And then I had this kind of goes into my other passion for chronic pain. I had a client that was 22 years old, female, 6-month-old baby, was in a fairly minor accident, had some whiplash. She was in school online. And she had headache, she had fatigue, she couldn't hold her son for very long, all of these things after the accident. And within 2 weeks, she came to us very early because she was a relative of another PT in the clinic. And So within a couple weeks, we had it all cleared up. Maybe a little bit of neck pain still, but the fatigue was gone. She was able to do anything she wanted. She was holding her son, whatever. Well, because it was a car accident, and a lawyer was involved, they want imaging and they want to be seen by a doctor to maximize the payout, basically, get as much as they can in the settlement. So she goes to the doctor, and this is someone that I had already kind of primed her for what she might see and what she might be told. And so she goes and gets an MRI. And so she goes and talks to the doctor. She comes back to me and we kind of debrief the doctor's appointment. I was like, okay, what's going on? And she said, well, I have arthritis in my back or in my neck, and the curve in my neck is decreasing. And I said, okay, well, what did the doctor say after that? She said, nothing. He walked out of the room. I was like, huh. So how's your pain? She's like, well, the MRI machine kind of messed it up because it's, a rigid surface and it's uncomfortable. But kind of the fatigue and everything else is starting to come back. And I was like, well, what does all that mean to you? And she's like, well, I have arthritis in my neck now, so I'm going to have to be protective of my neck. I'm going to have to limit how often or how long I hold my baby. I'm going to have to adjust my workouts. I'm going to have to make sure I'm not staring at the computer screen for too long because I know that I might aggravate this thing. And that's the complete wrong attitude to have, right? Studies show they're imaging people who have never had pain before, and they're imaging their back, their neck, their knees, their hips, and they're finding, and it increases with each decade of life, people that show these degenerative abnormalities that never have pain, right? And so it's so easy to go to the doctor and the doctor says, oh, look, I can physically see this and I can point it out to you and you have pain in that spot. So I'm going to say, okay, this is why, right? And then once you have arthritis isn't going to go away. That degenerative change isn't going to go away, right? Like you're not going to take an image when you're 20 and see arthritis and then take an image when you're 40 and then it magically disappears. So you're basically giving someone that diagnosis and saying, here, you have to deal with this all your life. Well, the arthritis didn't come from the car accident, most likely. And so if you would have imaged her neck a week before, a day before the accident, she still would have shown those same things, most likely. And she would have never known about it, and she would have kept going along with her life and not knowing. So what I see 30, 40, 50s is people getting these diagnoses and then like really owning that diagnosis. I can't do that because I have arthritis. And, a lot of people come to physical therapy. I have arthritis and the doctor says I have arthritis and he says I need surgery and there's no way you're going to cure arthritis. So why am I here, kind of thing. And so we have to really break down a lot of preconceptions about pain. And that all goes back to having, like, owning kind of your locus of control of your body and being mindful and aware of your body, and not letting like a biomedical diagnosis dictate how you're going to live your life.
So what did you do for that lady in that car accident? What was the kind of the regime afterwards to get her back into?
I think probably because she was primed before, and she has regular contact with her relative that's a PT that understands all this the same as I do. It really just took a couple more treatments, and part of it was it was aggravated because of the MRI. But I think there was just a few more treatments because we broke down that barrier so quickly, because it was, within a week that she had started those thoughts, and then like, oh, this is what you're talking about. Okay, I get it now. But the last I heard, she's doing great and she doesn't have any pain.
Oh, that's interesting. So it's like a self-fulfilling it's a bad prophecy, and then people are just being careful after hearing the bad news from a doctor in that case.
Right.
That's really interesting. That's sort of how I feel with my ankle. So I was in a car accident about 5 years ago, shattered my, I forget how to correctly say it. I want to say talus bone, but I think it's talus. Is it talus bone?
Either way.
That shattered, so now it's got 3 screws in it. And at the time, being under OxyContin, that's another story, but you don't think straight, you don't know what to do for your foot. And it wasn't until I think about 4 months later, the doctor never told me to go weight bearing. So at the 4th month, I was like, hey, am I supposed to get on this foot? And like her eyes like lit up, like, you're not walking yet? I'm like, well, I'm waiting for you guys to tell me what to do. I don't know anything. And secondly, I'm on all these drugs. I don't even know what to think straight. So there was that. And then the other part that surprised me was, it was about, I forget how long into it. I'll just, maybe 9 months in from the car accident, where I'm doing a checkup with a doctor. And I asked the doctor, so I visited this other doctor quite a few times. And then on like the 4th visit, I asked, so what do you think about stem cells surgery? And then her eyes lit up. She's like, yes, 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 do that. And I'm like, why wasn't I told this like 9 months ago? And I think I understand from a medical side. I think the doctors and or the government's very careful with stem cell surgery because it hasn't been fully proven in there's a lot of information out there that says it's good, but I think it hasn't been vetted through our system. So to think that when I'm going through that, I might be under a lot of drugs and I don't know how to deal with it. I don't even know what to think straight. I don't know anything about that bone. So like a little bit connected to what you're saying, at the 4th month when I haven't been told to weight bear, I kind of just took what they were giving me. The doctor's like saying, hey, just rest up. I wish I would have pushed that. I wish I would have done the stem cell surgery. I wish I would have been weight bearing a lot earlier. There could have been maybe a chance for the bone to stay alive. So anyways, yeah, I definitely connect a little bit with what you're saying about if you get a chance to go deeper into the diagnosis. But that's an interesting thing, as in how should an average person know to go deeper on that stuff?
Yeah, and I think, if you think of how much a physician has to know, especially like a primary care physician, it's a lot, right? So, why are we expecting them to know specifically about pain or these injuries? Yeah. So did you have physical therapy or?
Yeah, I did. And gosh, how long was that in? If I remember, gosh, it's 5 years ago. I don't remember fully. I think, I want to say it was 6 months in that they got me to physical therapy. Now I'm thinking back, like, I remember somewhere saying that they wanted me, I saw some on documentation that they wanted to get me weight bearing within 6 weeks, but it was buried under all the paperwork. So it didn't connect the dots for me with that. I wish I would have asked the doctor earlier, but at the second, on the other side, maybe the doctor should have told me at 6 weeks, hey, get weight bearing, because I was visiting a doctor like every week. Sometimes multiple times in a week. So yeah, it was about 6 months later when I think it was 6 months later when I got into physical therapy.
Yeah.
So you have, you mentioned in our emails prior to this about opioid crisis. What's your thoughts on that? That's a super close subject for me.
That's really interesting, frustrating, revealing, all at the same time. So I used to be the treasurer for our Arizona State Physical Therapy Association when I lived in Arizona. And I had started a student group in Arizona because there was a lot of legislation going on, and my political science degree kind of kicked in and said, like, hey, what can I do about this? And so I was able to go to Washington, D.C. and advocate a couple times on behalf of the Physical Therapy Association. And so right at the end of my last rotation for school, I was going to start working at that clinic when I graduated and start the residency. And the current treasurer worked there, and he was going, he was leaving to another state. And so I basically got told, like, as soon as you graduate, you're going to take over as treasurer. Like, completely had to learn on the fly what was going on. But I really wanted, Arizona was taking a very firm stance on the opioid crisis. And so I reached out to the bureau chief of the Arizona Department of Health Services, I think was his title. And, you know, I went in to talk, like, how can we collaborate to work with people with chronic pain, and how can physical therapy help the crisis? And it wasn't until like halfway through this hour-long meeting that he's like, oh my gosh, you know what? You should come to our pain summit. And I'm like, pain summit? What is this? I haven't heard anything about this. He's like, oh, it's so cool. We reached out for input from every prescribing provider school in Arizona. So any medical program, pharmaceutical, or I think pharmacy was involved, vets, even dentists, physician's assistants, nurse practitioners. We got input from all of them and developed a pain curriculum that we want them to pledge to have within their medical program. And I'm like, how is there's a DO program, there's a dental program, there's a physician's assistant program at my physical therapy school that were participating in this. And at no time it seemed like did anyone think like, hey, let's reach out to physical therapy or some other profession that doesn't prescribe to get their input on how to treat pain. And so I was like, okay, well, you know, when's this pain summit? And so I was able to go, and I kind of asked for permission for a few other PTs to go. And so they were basically unveiling this initial curriculum. And every time they were talking, they would say, anytime they would say anything about any mental well-being, mental health, or yoga, or physical therapy, or any of that stuff, it was always alternative therapy. And I'm like, why is this alternative therapy to putting in some synthetic thing into your body? Like, this should be the main therapy and then adjunct with opioids. And so it was really eye-opening to me. They were very much discouraging going to, what did they call it? Basically, continuing education events that were put on by industry. So basically by pharmaceutical companies. And it was kind of clear how deep it had gotten into how much influence the pharmaceutical companies had in getting these prescribed. I had people from the VA and other places that they were just kind of like, okay, here you go. The crazy thing about one of the crazy things about opioids is, number one, it actually makes your central nervous system more sensitive. So you have more pain. You have to continue to take more to get the same effect. And so these people were coming in saying, okay, it's not working anymore. And they would just give them more. So I've seen people on obscene amounts of opioids. And then when the crisis hit, they all just basically got told they were drug addicts and they're not getting any more, right? And there's a tapering process that they've developed that can kind of reduce the withdrawal symptoms, but that wasn't happening. They were just saying, okay, they say that I can't prescribe this anymore, so you don't get any. Or now, you know, primary care doctors, a lot of them don't prescribe opioids. You have to go to the pain specialist. And so that really opened my eyes up. And so they were talking about, you know, this interprofessional collaboration where you should be reaching out to physicians and physical therapists and having kind of that network. And I was the clinic director of a clinic at that time. And so I was going to physicians, like loaded with this new curriculum saying like, look at this, this is how we treat kind of the whole person, not just pain. And it was kind of staggering, the blank looks I got, because it was just like, that takes an effort outside of seeing so many patients a day. And the medical system that I've seen is stretched pretty thin. So like as a physical therapist working at a busy clinic, I could see 2 to 3 patients an hour. Physicians see, I think up to like 8 people an hour, or 8, you have 8 minutes with the doctor. So they're seeing a massive amount of people, and there's no way to have that human connection when you're seeing that many people. And there's no way, like when I start talking about mindfulness and I start explaining pain to people and educating on that, there's no way you can do that in 8 minutes. There's no way a primary care physician, like you're not seeing someone like multiple times a week or even multiple times a month. It's just to kind of like check in. Should we change anything? No. Okay. Keep going. Yes. Let's change this. So the education piece where you can really embody, give the patient that control back, or reduce the risk of them losing that control, is really hard to do when you're seeing so many people, I think. And so, coming out here to San Diego, it's a completely different medical system, and it's kind of run by HMOs. So you have Kaiser and you have Sharp, and they have their network, and they are basically dictating how you're going to care for that person. And so I just, there's kind of a groundswell of this cash-based system of mobile physical therapists, that, you get to decide how often you're seeing the patient. You get to decide what you're doing with the patient. And so it's been pretty liberating in that sense, for sure.
Yeah, that sounds, I don't think I've ever heard of a mobile physical therapy unit before.
Yeah.
Do you know if you happen to be one of the few in San Diego, or is there a lot others, or?
So there's a network of us. There's definitely a few that I know personally. And then every once in a while I see it kind of pop up. But we're not marketing. We don't have the marketing budget of Kaiser and Sharp. And even, in the past, even since I graduated in 2015, there was a lot of independent physical therapy clinics that got bought out by bigger clinics. And so now you have one that is just absolutely everywhere. So they have the ability to market quite a bit more. But, when we're doing, what I've been working on is just hyper local, sticking to East County. And then once you get the word out, and once you see a few patients and they see how much it's different, then, hopefully word of mouth starts taking off and that kind of stuff. But, unless you're in a conversation with someone and you start talking about physical therapy, or if someone, comes to me or I go to them for physical therapy and they know someone else that could benefit from it, then you're not really going to hear that it's happening,
Yeah, I could see.
Like people sit down around the kitchen table and talk about what physical therapy clinics are doing.
Yeah, and the hyper localization might make it kind of, because you got to advertise, because they might be sitting around the dinner table talking, but then unless they're in that area, if they live specifically in that area, that right. Might make it tough. Jumping back to the opioid thing, my personal story with it, so for about 4 months, I was on OxyContin, I think 25 milligrams, four to six, I think 4 times a day. And I remember going to the pharmacy, picking up the drugs. I talked about this in depth on my podcast, where I talked about marijuana and psychedelics, but I was trying to talk about how my view on OxyContin and opioids is I don't like that situation, the opioid crisis. I'm lucky it didn't get worse, I feel like. So I went to the pharmacy, picked up the prescription off two times, where the pharmacy tech handed me the prescription. They like, why are you taking this? This is so much. and their eyes like lit up. They're like, or lit up in the sense of they're like fearful for me. I could see like a fear on their face. And at the time I had like a big boot on my left ankle. I had a cast on my left arm, and I was on a knee scooter, and I'm like looking at them, and I'm like, don't you see what I'm like doing here? Like, this is a lot of pain, so this is why I need it. But I didn't know anything about OxyContin at the time. I'm just taking it as painkillers. And so I'm taking OxyContin for four months, and luckily something in me just said, hey, let's get back to normal, meaning we need to get back to not depending on anything, and let's get back to normal life, or hopefully someday I could play racquetball or something. Luckily, the OxyContin, I didn't get addicted. I hear of other cases where it's super addictive, but my own personal thoughts on that thereafter is I could have easily went in and got more OxyContin. It was simply that I decided to stop. I could have easily prolonged that medication, that prescription, for so much longer. Mm-hmm. So to hear you say that, where like it gets diluted, the feeling of it, so you need to take more and more, that would have sucked. So then now around 4 to 6 months after I stopped, I noticed more of the withdrawal, or I don't know if the withdrawals, depression. So I don't know if depression is part of the withdrawals or how that all works out. I don't know the definitions, how to define or the correlation of all that. But I think the depression was due to the opioids, I think. And they were really it was really heavy depression. It felt like it lasted 6 months in total. So about 5 months after I stopped, the depression was heavy. 6 months, it was heavy. When I think back, I'm really pretty pissed at the OxyContin situation there. I feel like I'm fortunate that it didn't get worse. I got lucky that for whatever reason, I theorize maybe my body and maybe addiction is like my tolerance to addiction might be lower. So I think I just got fortunate. It could have been easily worse, I think. It sucks that the doctors or the pharmacy, maybe more on the doctors, that they didn't have a better regime to taper off using OxyContin, or even just ask about it. They never asked. It was almost too, I actually think I remember at one point, if I remember correctly, one of the checkups with the doctors, the doctor just asked, "Oh, how's the pain?" I'm like, "Yeah, it's still pretty bad." And the doctor's like, "Do you want more OxyContin?" It was just, I could have easily said yes, and she would have upped the dosage, but I just said, go ahead, keep the dosage as is right now. It seems just very unfortunate with this opioid crisis, where it's pushed for the doctors to go ahead and readily prescribe it. The pharmacy, they don't question it, which I don't think it's a place for the pharmacy to question it, but it's a shitty situation altogether.
Yeah. And I mean, that goes back to, how many people did that doctor see in that day? And, how often were you seeing that doctor? If it was, once a month, then like she can't, for me personally, I bet there's some really smart people that are able to maintain the kind of memory, but like on that timeline, they can't like experience your life right at that moment. They're getting little glimpses by what you tell them, but everyone is so different that there's not like okay, this month we're going to start tapering to this. And I was going to ask you, like when they gave you OxyContin, you said you were taking it, I think, 4 times a day. Did they tell you anything like, don't get behind the pain, make sure you're taking it almost prophylactically so that you don't experience pain? Or did they say like, hey, if you don't need it, you can skip a dose, you don't have to take it 4 times a day?
No, they basically it. I feel like there's no information whatsoever. They didn't tell me about the addiction, like possible addiction. They didn't tell me when to use it. They didn't tell me try to use it if you feel pain and try to skip. Yeah, they never said anything about it.
Yep.
That's crazy.
Well,
What's your
your experience would be completely different now, I bet, because it would be a lot harder for you to. Be a lot harder for the physician to justify giving you that high a dose.
interesting.
But I mean, on the other side, there are people that have chronic pain that works for, and there is nothing else that's working, and they're functional with it, and their life would be a lot harder if they didn't have it, right? And
Yeah.
you mentioned depression and pain work hand in hand. So you have chronic pain. I don't know how limited you were physically when you had the depression, but if you have a feeling of, gosh, I can't walk anymore, or am I ever gonna be able to walk? Am I ever gonna be able to do this with my family, my kids? Am I gonna be able to provide for my family? All those things. A lot of times, again, we're not mindful in general as a society, so we aren't. We don't have that metacognition to think about our thoughts, and so we just experience all those things and all those fears and all those, and we just let them happen to us, and it lets us spiral into that depression.
Yeah.
So cognitive behavioral therapy is something that I really, really like. And I use a form of CBT with physical therapy because it's all, your beliefs, your thoughts, and kind of understanding and knowing and mastering the dynamic between your thoughts and your beliefs and your emotions, basically.
Yeah. A couple of days ago, just did a conversation with a social worker, but it's a social worker that deals with psychology. So it's basically almost like a psychiatrist.
Mm-hmm.
And that was really interesting to talk. Kind of what you're saying a little bit connects with that.
Yeah.
It was a really fun conversation. When you say chronic pain, what's your perspective on it? What's the different types of chronic pains? Let's start with what's your definition of chronic pain?
Oh, so chronic pain to me is, I actually have a chart in this book, but if you think of a tissue injury and then a normal cycle of tissue healing, and then pain lasting longer than that normal cycle of healing.
Okay.
So all tissue has a pretty specific timeline of how long it should take to heal. And so chronic pain is kind of something that people experience after that injury has healed. Or maybe, weight bearing, you might be causing little micro injuries that whole time. And so you have prolonged pain. But if you have it for, more than a month, more than 3 months, then that would be considered chronic pain for sure.
What are some of the most common chronic pains that you deal with?
So I think that's kind of one of the problems we have right now. So in our medical system, we have something called ICD-10 diagnosis codes. So, low back pain is a diagnosis code, unsteadiness on feet, generalized weakness. Those are all specific diagnosis codes. When it comes to pain, there aren't a ton of options, I guess. And so right now, for a lot of people, we cluster a lot of people together into a diagnosis of fibromyalgia syndrome. But what we know about a syndrome is it's not like you take a test and the test comes back cancer, right? It's not like as cut and dry, or you fall and and land on your arm and the x-ray shows a broken bone. Like, it's cut and dry. It is broken, right? Fibromyalgia is basically one of the biggest tests for it is you're just sensitive in a certain cluster of areas when someone pokes you. And so what I try to tell people is that fibromyalgia is just a thing that we use in our documentation. But really, if we got better, more advanced at our ability to isolate different conditions, people with fibromyalgia would significantly decrease because we'd be able to identify more specific reasons for their pain. But even that goes too much into the biomedical explanation. So we treat what we were taught in school, and kind of that's kind of being challenged right now. But we have a biopsychosocial approach to pain. So there's the bio, like you broke your arm or the tissue's torn, and then obviously the psychological and the social. So what psychological context is this in? Are you already someone that's predisposed to depression? You already have depression. What kind of, and then social is the relationships, right? Are you able to work? Are you not able to work because of your pain? What happens when you go and talk to your spouse about pain? Typically, one of two things happens: either the spouse or your family coddles you, and you get everything done for you, or they say, like, they kind of ignore it, and you're forced to do these things that increase pain. Both of those things can increase pain, right? And so when I treat someone with chronic pain, it's more digging deeper into their beliefs and their actions and what they do throughout their daily life and what their goals are, what their motivations are. So it really doesn't matter specifically when we're talking about that, the specific where the pain is coming from, but just kind of addressing the underlying symptoms. So I had a client in Arizona that came in, really bad historian, couldn't really tell me a whole lot about where her pain was, why it was there, even where it was, and she had a hip replacement a few years before, and no pain relief. And they just kind of said, like, well, okay, I mean, there's that's what we can do. And so she came to me, and she was older female, lived by herself, had the TV on at night, was playing video games, this like card game where she was playing with people that she didn't know, just like in the internet. And she would get really frustrated. She was just like really tightly wound. And so, I started doing some manual stuff, giving her a little massage on her hip. And, but then I was giving her what she wanted, what she expected from me. But then I was like kind of going into some sleep hygiene about having the TV on, and then also how much her central nervous system was just getting ramped up just by playing this game and getting so frustrated with it. And so I took someone that was completely, like, anything outside of the tissue is the issue that's causing the pain is completely foreign. She turned the TV off at night. She stopped playing the game. We had like specific times of the day that she could play it, and only for a specific amount of time. And then we did some like deep breathing and mindfulness stuff, and it completely took her pain away. So if you said, where is her pain coming from, or why does she have chronic pain? Well, there's probably some irritation in her hip that is coming from a tissue, but kind of taking control of that and addressing these other areas of her life that were contributing to it completely resolved her symptoms.
Wow, that's amazing. How do you? I'm thinking, what about people? So she came to you and she found that out. I'm imagining she probably would have wished she would have came to you much earlier in her life. Is there a lot of that happens where people say, "Dang, I wish I would have addressed this way earlier"? Is that a common thing that you run into?
Yeah, it was. So when I worked in a pharmacy, the interactions with people are super fast. right? I mean, I was just a cashier basically, but even if you talk to a pharmacist, you know, they only have a few minutes to talk things over with you. And I have not worked in a big clinic or a big company that is all about profit. So you see, you know, 4 patients an hour or more. But what I hear from patients is you barely get an initial evaluation. That first visit that you come to see them, they're just kind of basically screening you for more sinister pathologies and then like just kind of kicking you out to a tech. And so even in the evaluation, like halfway through an evaluation, they would stop the evaluation and say, like, this isn't physical therapy. This isn't what I'm used to. I'm used to, you know, like this, like going in and basically no interaction whatsoever with actually learning my story, right? No one has actually heard my story or cared about my story. And so like a client came in Arizona that he has severe osteoporosis, and it's totally atypical for a male in his I think is in his 40s to have severe osteoporosis, but he's basically broken every vertebrae in his back with very minimal injury or cause for an injury. And so, you know, we posterior pelvic tilt is something that we do a lot with low back pain patients. And basically, as you move your pelvis, you're moving your back too. And when you're moving your back, you're contracting and relaxing all the muscles around your back, which there's a ton of them. And so what happens, in my view, what happens, like when you hurt your shoulder and you don't know why, you don't need to go to the doctor for it, but man, it hurts. You kind of hold it and protect it, and you kind of hold it to your side. And then every once in a while, your brain kind of forgets about it. And it's like, oh, I need to reach for that cup. Oh man, oh, that hurt. I need to stop doing that. But then eventually you keep reaching for it. And then you don't even remember when it happens that you reach for the cup and it doesn't hurt, right? If someone asks you 2 months after the pain resolved, if you get asked when did it stop, you're like, oh, well, I don't know. I just started doing it. We don't necessarily do that with our back, right? Our back, we protect it, and then you can squat, you can bend down, you can reach for things, and basically keep your back still, relatively speaking. And so this guy came in and he was told, like, the doctor said not to move my back. I'm like, okay. And the doctor like would not let him go to physical therapy for a long time. It took a lot of advocacy on his part to even go to physical therapy, because they thought that we were going to make him do something that was going to break his back again, basically. And so I had him just do some pelvic tilts, and he's like, well, wait a minute. He said, you know, I know how to do this. I've been to physical therapy before. And so he did it, and he basically just contracted his stomach muscles. His back didn't move at all, right? So not the point of a posterior pelvic tilt. And so he talked about, you know, why he was doing it that way. And he's like, I've been to, you know, years of physical therapy, and they just say, hey, do this posterior pelvic tilt, and then they just leave. And so that's what I've done. And so I just put my hand under his back and said, like, hey, you know, push into my hand, and his back actually moved. The next visit, that's literally the only thing that we did. No manual stuff, no massage, no nothing. He came back, and his pain for the last 15 years that he's had this pain was 80% better, just because he started moving his back. And so, you know, chronic pain, that fear of moving, and you're not moving your back, you know, can gradually increase your pain or maintain your pain.
Wow, that's amazing. If there is a general statement you could say, if someone who should think about coming to see you, like as soon as they feel a slight pain or they just feel something's not right, how would you describe it when someone should come see you?
Yeah, I think, you know, I think I'm going to get this wrong, but in physical therapy school, they told us of a survey that like only 10% of the people that should get physical therapy are actually getting physical therapy. In places like Arizona, well, almost all all states have some form of direct access for physical therapy, meaning you don't need a doctor's prescription. But once you deal with insurance companies like HMOs, a lot of them you need pre-authorization for them to pay for you to go to a physical therapist. But in my perfect world, I have a workout kind of like a wellness facility that they're coming in, and there's personal trainers, and they're, making sure that they're working out. And then if they feel something, you just come and talk to the physical therapist. You just kind of have that, like, hey, what do you think about this? And then immediately the physical therapist can like kind of decrease that catastrophizing about the pain. And then you can monitor it and like, okay, is it increasing? Okay, let's see what we can do about it. But really there's a ton of people. If you hurt your back, like I just kind of messed up my back yesterday. I just stretched by putting my elbows up, and oh my gosh, I did something to my back, and it really put me out yesterday. But a lot of things went through my mind, like, hey, I own my own business. Like, I have to work. What's going to happen? I can barely move. Am I even going to be able to drive home, kind of thing? If I didn't have the education that I have, I'd be, laid up in bed for a week if I didn't know that I just had to keep moving. And so, yeah, anytime you have that fear of, I don't know what this pain is going to do to me, you should talk to a therapist. Absolutely. Even if it's just like hey, I want to check in, have an evaluation, and then just be told like everything's fine. I have a client right now that called. She's my first client. She called with knee pain. She has chronic knee pain, but it was a sudden exacerbation of pain. And the pain was gone by itself, almost gone by the time we actually set up the appointment. But I, convinced her that it was beneficial to continue with therapy. And she just had kind of the same exacerbation happen in her knee. And even after all that talk for the last 6 months of kind of talking about pain and everything like that, when I went and saw her, she's like, I think it's dislocated. I think all these like really crazy things, and it's like completely destroyed everything that we've worked towards. And, it just took a little conversation and coaxing and a few weeks of, it's going to be okay. And don't you notice that you're doing this better? And now she's, a few weeks later, she's back to exactly where she was before it happened. So, yeah, there's definitely, it kind of depends for each individual. Like, are you going to be able to deal with that pain yourself? Or are you going to start changing your life and changing your activities because of that pain?
So if someone's experiencing a pain that's changing the things that they want to do, it sounds like they should contact you. Now, with the way that insurance and primary care physicians are set up, when they contact you, do they have to first go to their primary care physician first and then get approval to visit you? Or how? Actually, I don't know anything about it, so can they contact you directly? Or
Yeah, so insurance is pretty crazy. When I set out to do this, I said I'm just going to take cash, because I've been the patient and gotten crazy medical bills 3 months later, and then come to find out there's some detail loophole that the insurance doesn't have to pay for. I had surgery on my nose, and 3 months later I get $1,000 bill because the anesthesiologist wasn't in network with the insurance company. It's like, how am I supposed to know that? Even as a medical professional, how am I supposed to know that? I tried to do my due diligence. I called the insurance company. I called the doctor. I called the hospital to make sure this was going to be my responsibility. And so I'm just going to take cash. Well, the first problem is Medicare. I can't opt out of Medicare, right? So I can't, technically speaking, I can't see someone who has Medicare, and charge them cash for something that Medicare covers, right? So, okay, so get in network with Medicare. So I'm in network with Medicare, And then with other insurances like Kaiser, and like if you have a Sharp HMO, they have their own providers. So if there's not like an urgent reason for you to be seen by someone outside of their network, they're not going to pay for it. Most PPOs have a lot more flexibility, and a lot of them have in-network and out-of-network benefits. So even though I have no relationship with this PPO plan, I can submit my charges to them, and they'll pay a portion of it. As for seeing a Medicare patient, they don't have to go to a doctor before they see me. All I have to do is send my evaluation and plan of care to the doctor, and they have to sign off on it and send it back. Now, if that doctor says, "Oh, I'm not letting you go to physical therapy until you come and see me because it's my signature, I'm authorizing this to happen," that's on the doctor. But most of the time, we just get a signed plan of care back. If I was in network with an HMO, most of them would say like, "Yeah, you have to go to the doctor to get a prescription written before you can go see the physical therapist." But anyone can call me and say like, "Hey, what do you think about this?" And I can no one fully understands the whole insurance system, but I can kind of guide them through like, here's how you can get through to that.
Okay. Yeah, the insurance system, man. Earlier when I talked about Gamestop and how corrupt that stock market seems to be, insurance is no better. Yeah, insurance. What's the other? Anyways, insurance is terrible. So if they have if they're curious, they should at least just contact you and then take it from there. Then you'll advise them on if their insurance would support it or if they need to go get a signature from the doctor.
Right.
Gotcha. To you, what is pain?
Oh man, I'm gonna read you the definition. Hang on. It's kind of ever evolving. So pain. This is from the International Association for the Study of Pain. The definition is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And then they have some keynotes that I usually don't talk about, but they're really powerful when you're talking about how we're treating pain. So pain is always a personal experience that is influenced by varying degrees of biological, psychological, and social factors, that biopsychosocial model I was talking about. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. I'll talk about that in a second. Through their life experience, individuals learn the concept of pain. A person's report of an experience as pain should be respected, basically saying, a lot of times, especially like for something like workers' comp, people have pain, but an image shows that it's fine, right? There's no like tissue injury. And so they're basically told you're making it up. But what we're learning now is, someone could always be making something up, but what we're learning is those people are likely not making that up, right? Although pain usually serves as an adaptive role, it may have adverse effects on function and social and psychological well-being. And verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. So that's kind of, I always, when I read that one, it's kind of the, if a tree falls in the woods and no one's there to see it, does it make a sound? So the pain and nociception are different phenomena is kind of a critical one for me. Nociception is the actual chemical, electrical signals from your nervous system. Like if I cut my arm right there, there is a predictable amount of nociception that's going to my spinal cord and then up to my brain, right? Pain is the output from my brain that it decides to change what I'm doing because of the actual or perceived tissue damage, right? So if you you hear stories of soldiers that are shot in battle, or someone's in a car accident and the car's pinned on a little kid, and they have this superhuman strength to move the car, or the guy gets shot and doesn't even know it, and after the battle only realizes that he's been shot, and the guy that lifted the car has a broken leg or something like that, and then he's in pain. So that sensory stimulus from the nociception is only one factor from all of the contextual environmental factors that come in, and so your output of how painful it is dependent on all of those factors. So I give this example. I sprain my ankle all the time, ankles, both of them, and I sprained my ankle once right before I was going on vacation. No, I wasn't going anywhere. I was just taking vacation, and sprained my ankle in a basketball game. Came home, had to walk upstairs to my apartment, could barely make it up. Lots of Vicodin. Oh my gosh, woe is me. I sat on my couch for a week and played Guitar Hero and got my vacation hours changed to sick hours. So there was no incentive for me to do anything different than just say like, okay, I get an excuse to sit on my couch and do nothing. Fast forward to physical therapy school, I was doing a Tough Mudder. I went to PT school a little late comparatively to my cohort. So I had these early 20-year-olds that were all athletic, and they wanted to do a Tough Mudder. I'm like, okay, fine, I'll do a Tough Mudder. And in the back of my head, I'm like, I don't know if I'm gonna be able to keep up with these guys. So to get into the starting block for the Tough Mudder, you have to jump over or climb and jump over a 7-foot wall. And so then I'm like, oh my gosh, I don't even know if I'm gonna be able to get over this wall. So I go to get up, and it was a lot easier than I thought. And so I propelled myself over kind of uncontrolled, and I came down. Basically, they had wood chips like angled going up to the wall on the other side, and I came down and just cranked on my ankle harder than I ever have before in my life. So like the first obstacle was running through this like thick mud. And I'm like, no, I can't do it. Like, I'm out. So I stopped the race. Well, that night I was supposed to go to Washington, DC and advocate for physical therapy. Paid for trip, get to go to DC, get to do something for my profession. And now I have this ankle that's just like bulging. I went to the medical tent to get some ice, and they're like, have you ever done this before? You really need to get this checked out. It's really bad. So what did I do? Did I go home and just sit on my couch for a week? No, I got on the airplane and I went to Washington, D.C. And if you've ever been to Washington, D.C., it's a lot of walking. And I, walked through the airport both ways. And I can't tell you exactly, but I'm sure that the second time healed a lot faster than the first time, because I got it moving early. The context was different. The context was I have to go to physical therapy school. I have to walk around Washington, D.C. I'm not going to have them, call for a wheelchair, and I'm not going to walk around Washington, D.C. on crutches or anything like that. And so the whole context changed everything. So when you think about like a workers' comp, is it someone that is happy to be at work? Is it super stressful? Do they have, are they, quote unquote, are they being bullied at work? Is it a good place to be or a negative place to be? And when you look at those factors, you start seeing like different perceptions of pain, right? And even they're doing studies of how much pain and disability people are in if they use a lawyer after a car accident to not using a lawyer. And if there's litigation involved, the pain experience lasts far longer.
So I think maybe a summary of some of the thoughts that I think you're putting in my head is, for a person you want to push yourself to a limit of what your body, like if you're experiencing something, pain in your shoulder, you want to try to push it to the limit of what you're comfortable with. If it doesn't go away in a month or 3, then contact someone like you. I think that's kind of a good summary.
Yeah, I mean, I think physical therapy can help guide you through that. So physical therapy is or was very guru based. There was kind of a few different leaders that you followed their treatment techniques, and this is what they propose is happening in the body when you're doing it. But then when you look at all of them as a whole, the guy that wrote that journal or whatever thing that I sent you last night, he talks about all of those things. When you break them down, it's initial unloading of the injured tissue and then gradual reloading, right? And so, if it's something that you just tweak your shoulder, tweak my back like I did yesterday, you might be able to just work yourself out of that. But if you need help in how much should I unload and when is it safe to reload, then get with a physical therapist. And even if they're doing that guru therapy, following those gurus, that's basically what they're doing, is they're helping you decide how much to unload and how much to reload. And then in our physical therapy program, they taught us SINs. So it's severity, irritability, the nature, the stability, and the stage. So severity, obviously, how much does it hurt right now? Irritability is this is a big one for people. Irritability is how much do I aggravate it by doing this specific activity, and how long does it last for? Nature is it muscular? Is it, you could say, like, is it bone? Is it neurological? And then the stage is it acute, subacute, or chronic? And stability, is it getting worse, staying the same, or getting better? So really, when you're looking at that severity and the irritability, we're trying to find that happy medium where it might increase some discomfort for a little bit, but if it's increasing for a day or two after that, maybe we pushed it a little too hard. And the nervous system, if for someone who has what we call radiculopathy, where a nerve is irritated and it's sending pain down your leg or down your arm, you might irritate it, let's say right now, and you won't notice it, but a few hours from now or tomorrow, all of a sudden your leg is super painful. So we kind of have to navigate those boundaries, which is what physical therapy can be really good at.
What do you this is maybe a question that doesn't really have that I don't think it'll really help anything, but what's outside of your wheelhouse? So I imagine a broken bone that someone needs to go to surgery, that's outside of your wheelhouse. I'm guessing once you've treated someone and they pretty much have a regime that's sustainable and they'll get better. So I guess that's out of your wheelhouse. So anything in between that, I guess, does that sound right to you?
Yeah.
Or am I missing anything?
So part of the reason I'm doing my own therapy is because I'm setting up this coaching aspect of what's going on. If you look at the two spectrums, or two sides of the spectrum, a normal outpatient privately owned physical therapy clinic, it's better for the business for you to be seen as many times as possible, right? Now you have to look at the owner or who's pulling the strings on how long are you seeing someone. There are some owners that really, really push, and they say, you know what, your average plan of care is scheduled for 12 weeks and they're only coming for 4 weeks. Like, what's going on? And then you have the opposite. So someone like Kaiser, who's both the insurer and the provider, they want to have as few visits as possible, right? They don't want to have to hire more physical therapists and pay more money to have their members come in. So my dad went to Kaiser for physical therapy. He hurt his shoulder and he got told, hey, you have a frozen shoulder, which I don't agree with that diagnosis, but do these exercises and come back in 6 months, right? And so because he didn't have a frozen shoulder, and even with the frozen shoulder, there probably is some things that you can do with physical therapy. You have to kind of manage those two sides of the spectrum, basically. And so what I want to do is provide physical therapy when it's necessary, but I want more opportunity for that lifestyle change. I want, like, okay, we've taken care of your knee pain, or it's at least manageable. Now let's get you walking again. Now let's get you going to the mall. So what are those longer term goals? So that client that I talked about, that I had over the summer, I have starting in the summer, she's transitioned to coaching. So it's not physical therapy, and she's cash pay. So if it was someone from insurance, at a certain point, insurance is going to say, no, we're not paying for that anymore. That's not physical therapy that we pay for, right? So then it would be like, okay, well, now if you want to, if it's something that interests you, are you interested in continuing the relationship with coaching and maintaining that level of function that you have?
I'm going to play a little bit devil's advocate, but your personality seems like you really do care about people and you care about getting them better. I'm going to play a devil's advocate question. So if someone were to look at your practice and question that, are you really trying to fix the problem, or are you just trying to get people back and get money?
Gotcha. There are people always drop off your schedule, no matter who you are, because personalities just don't happen. So a lot of the people that I saw, especially through my residency, that came in and said this isn't physical therapy, were kind of jaded about physical therapy before, because they felt like they just went in and got a hot pack and electrical stimulation, and then the therapist came over for 5 minutes and rubbed on their back, and then they went and did exercises for another few minutes with an uneducated tech, and then an ice pack when you're done, right? Physical therapy payment used to be a lot more geared towards that kind of service. Like you can bill for the hot pack, you can bill for the electrical stimulation, you can bill for the cold pack. The way that physical therapy is billed now within the system is it's a unit for every 15 minutes. So if you come to me and I rub your back for 8 minutes to 23 minutes, because there's an 8-minute rule, at 8 minutes you can bill another unit. So 15 minutes can break down between 8 minutes to 23 minutes. If I do 24 minutes, then I can bill 2 units. Then you break down what you're billing. It's either manual therapy, neuromuscular reeducation, therapeutic exercise, and the gait training. There's a couple more. So what happens is, if I'm seeing 4 people an hour, you're not there for 15 minutes, right? I'm going to see you for 15 minutes of manual. That's 1 unit. And then I'm going to have this list of exercises that this other person is going to take care of that I'm supposed to be updating and making very specific to you. But a lot of times I'm sitting there with a lot of people thinking, like, you can do this at home, right? But I don't get paid if you do this at home. And so you're usually there for an hour or anywhere close to an hour. And that makes it so that the therapist can bill for those units, right? So if you feel like you're not establishing a rapport with the therapist, if they don't remember you from Adam the second time they see you, if they're with you and if there's 2 therapists there and there's 30 people in the clinic doing exercises, you're probably barking up the wrong tree if you want that personalized care. But then a lot of other people kind of take advantage of it and say, well, I get to come and work out and my insurance is paying for it, kind of thing. So it's really personal. Not everyone would benefit from my services. An athlete, a high school athlete, depending on schedules and stuff like that, there's a lot more equipment in a traditional physical therapy clinic that they might be able to use to get them better. But everyone's in a different spot in their life. And so, ultimately people have to be better advocates for themselves. We've given too much control to the providers to just tell us what to do, to just tell us to keep taking this is OxyContin, right? And we don't know when to question. Like, why would you ever know to tell the doctor that you shouldn't be taking OxyContin? Like, it's their job to tell me to take OxyContin. Why would I'm not going to belittle my doctor by saying like, no, you don't know what you're talking about, by saying I don't need OxyContin, right? But it's really those people that are advocates for themselves and understand that they're working within a imperfect system that ultimately do the best.
Yeah, when you talked about the physical therapy, that's exactly how I felt with when I had my broken ankle and afterwards getting the physical therapy. It was exactly each week. I forgot if it was weekly. I go in for an hour. They would do their exercises, what seemed like 45 minutes, and then 15 minutes talking. And then even that talking, there was, I don't know how to explain it. It felt like the person did care about me, but their view on holistically fixing me wasn't there. I don't know how to explain it. Meaning they're like, oh, are you in pain? Oh, let's try to do this to fix it. But it wasn't fixing the root. It was like as if they were on some type of written program to say, oh, this might work. But there was no, it felt very, it didn't feel personal. It felt like they had a written program they had to follow. And then even I think once a month then they would have me talk to I don't know if it was the main physician there or whatever. I don't know the terminology. So there was a special person that I would just kind of update with every month. I think it was only 15 minutes. I would talk to this person. He would check, okay, do you think these stretches are working for you? Do you think this is working? But even then it felt like he was somehow scripted to do his job. It did feel like I could see his eyebrows, his face, like he did care about me, but yet there was a script that he had to follow.
Right.
And I want to say I did feel like it helped me a little bit because they told me what stretches to do, but it wasn't a holistic image on what I felt like could have made me better. So that's what when I talk to you, that's what I feel like you're trying to do. That's what I get from you talking to you.
Yeah. So everyone that I went to school with, I love. They got into it for the right reasons. They want to be physical therapists, just like physicians. I think physicians, very few people get into medicine without some level of like, I want to help people, right? I mean, that's what any interview you go into. Why do you want to be a physical therapist? Why do you want to be a physician? If you're not saying I want to help people, then you have a problem, right? But it's the system that we work in. And it's unfortunate. I mean, ultimate best case scenario, there's a physical therapist and a physician for every single person in the world. And you have that personal relationship with your team, right? That's not going to happen. But how much we load our medical professionals is kind of up in the air. And we like, for instance, last year, through some process, CMS, which is kind of it's the Centers for Medicare and Medicaid, basically the determiners of reimbursement for physical therapy and everything, basically. Their formula, they calculated out, they wanted to reimburse primary care physicians more. And so what did they do? It takes an act of Congress to say like, hey, you can spend more money. And so they took it from other places. So physical therapy was slated to get cut 9%. And I mean, it's not like we were getting increases before. Every year they reimburse less and less. And it took, with the COVID and the spending bill wrapped up in that, they cut the cut to 4% instead of 9%. And so every time, and this is where I feel like, I've only been in physical therapy a relatively short amount of time, but people used to have like $10 copays, but the insurance company paid quite a bit, right? And so the patient is looking at it, the value as, was that value good enough for $10? Yeah, sure. I was there an hour. I got a hot pack and a cold pack, and the PT came and talked to me, and I got some exercises. Like $10, that's a steal. And then reimbursement started coming down, and copays started coming up, right? So both caused by insurance, right? And so now you're looking at, from the practice perspective, you're looking at lower reimbursement means I have to see more people. And from that patient view, they're saying I'm paying more and I'm seeing the physical therapist less, right? So we had some people still have $0 copays. Their value of physical therapy is much different from that person that has that $60 copay, that $50 copay, right? You're not going to get off giving a massage for 5 minutes and giving that impersonal care and attention, and that person's going to pay $50 every time they come, right?
I think I'm following. I might. So will with the lower copay, but wouldn't the copay still have even if it's a $60 copay, maybe the insurance company, I don't know, they tack on like $300 to do. Oh, no.
Yeah. Well, so they're calculating, and we're calculating. Everyone's calculating. $10 copay. Okay, the practice gets that $10. Let's say $150 total. So the patient's going to pay $10, and the insurance company pays $140. Right.
Yep.
The increase in copay and the decrease in reimbursement doesn't equal 150. Maybe now it equals 120.
Oh, right? I did not. Okay.
So, it's kind of a lose-lose situation. It's a lose-lose-win situation, right? The insurance company wins and they have all the power, and the patient loses because they're paying more, and the practice loses because I got to see more patients to make probably even less than what I did before.
Wow.
So
okay.
what it sounds like you did was you saw either a physical therapy assistant or a tech, and the PT was the one that was coming in once a month getting updates, right?
Yep.
So I mean, physical therapy assistants can be fantastic. I think it's probably like a 2018 or 24 month program. It's a certificate program. I know lots of really good physical therapy assistants, but it's all in how much effort you're going to put into it, right? There's good physicians and bad physicians. There's good PTs and bad PTs. My general view of professions in general is how much skin you have in the game, right? How many years did I devote to being a physical therapist? How many years does a physician devote to being a physician? I think that is a big factor in how you care about your clients, how much ownership you have in their care, right? So a PTA can see a ton of people and get burnt out just like a physical therapist and a physician. So yeah, and you said it seemed very, I think a word for it would be mechanical.
Yeah,
right?
yeah.
A cookie cutter.
Yep.
And it is because we have to document to insurance companies specific things to say, like, this is how they're progressing, right? So it might be that your ankle went from 10 degrees of dorsiflexion to 15 degrees of dorsiflexion. Now I can say, hooray, we're making progress. So that's justification to the insurance company. But you don't care about that. I mean, you do a little bit. Like, okay, that means that I'm progressing, but you're trying to get off the knee scooter. You're trying to get out of the boot. You're trying to go back and do the activities that you did before the accident. Mm-hmm. And a lot of times that gets lost because we're searching for those things that we can justify to the insurance company to improve, to continue to see you.
Yeah. Wow. So. Dang. It's so interesting on that topic. Like, even seeing, I have a friend who he's got shin splints, and I think that I'm probably ruining the story. I think the doctor's prognosis was some type of micro fractures in the shins or something, And then my friend is just saying, shit, what do he feels like he takes relatively good care of himself. He's fairly active, and he's just like, fuck it. Like, if my body's just falling apart, maybe I will stop like working out. And not, I mean, he's just kind of, it's just, maybe the doctor's not giving him, and this is like you're saying with insurance and everything, maybe the doctor's not thinking about a holistic view on, maybe you should do this for your shins, maybe this. So it's, maybe that friend should come see you, but it's.
Well, I mean, if you look at it from that perspective, usually shin splints might be is commonly associated with running. So I don't know how active he is, if he's a runner or something like that. But the doctor is not going to, I don't think most doctors have the time to get into his story enough and his daily routine enough to say, we're going back to that unloading and loading, right? This is what I want you to do to unload it. And then in a couple days, I want you to try this to reload it. And then this is where we're going to progress from there. So that's something that a physical therapist, the fantastic thing, even though I'm complaining about, the 15 minutes and seeing 4 patients an hour, there's not a whole lot of medical professionals that get more time with patients than physical therapy does. And so we're able to use that time, if we use it effectively, to really not just say, here's this manual guru technique that I have to take away your pain. That might help in the short term, but what's that unloading loading program look like for you?
Yeah. Man, insurance. I blame insurance.
Yeah, absolutely.
My wife has a question. During cold weather, her legs seem to ache. I try to ask her, is it bone or is it joints? And I thought it was going to be joints, but her answer, she thinks she was, I think it's, she maybe hasn't had that pain in a little bit. So she can't remember exactly where in her legs. So she was asking, what type of medicine or treatments would you suggest? That's probably super vague, so that might be tough for you to answer.
Yeah, being active.
Just being active? Okay.
Yeah, the more you move your joints, even for people with, my jury is still out on weather changes and stuff like that. I've been told that it's all in people's heads, or broken down, it's all the other environmental factors. And then I worked in a place where it was a very high senior living population, and man, they, like clockwork, when the weather shifted or when it got cold, they come in and say, oh no, it's okay, it's just the weather. And it's like, man, this is like really on point that all these people are saying the same thing. So whether it's barometric pressure that changes along with temperature, the way that your cells are interacting when it's colder, but the more you move, the better you're going to be. And so even with people with severe arthritis or degeneration in their spine, when it starts stiffening up, the best thing that you can do is move, because you get more synovial fluid in those joints to help with the lubrication.
Yeah. Kind of just a tangent when you said the barometric and you think that the jury's still out. I would be in that boat. So with my ankle, I got 3 screws in it. Through 5 winters so far, I haven't seen any correlation with being able to predict weather or whatnot, or having more pain during the winter or not. There was one very unusual situation where I took an airplane. I flew to Vietnam. I've flown to Vietnam twice now, so that's one. That's four plane rides, because one there, one back, one there, one back. Only one time, it felt like someone. Let's see here. It was when I was in Taipei. So the first flight from Vietnam. On the flight from Vietnam to Taipei, then to LA, then to Vegas. So while I was in Taipei, it felt like someone took a pin, like a writing pin, but didn't and was stabbing it into my ankle. But it didn't feel like a knife. It didn't feel like a super sharp pain. It was like a dull, intense pain. the only thing I could guess it was so bad where I had when I went to Vietnam, had a lot of luggage with me, so I had my cousin with me, and I said, hey man, can you carry all my luggage? I'm so sorry. I could barely walk. It was pretty painful. On a scale of 1 to 10, I would say it was like a 7 out of 10. It was pretty bad. Yeah, so I don't know. My guess is maybe the altitude, but it's weird that it didn't happen when I came to LA. It didn't happen when I came to Las Vegas, and then it didn't happen the other 3 times. So it was 1 time out of 4 flights. Actually, and then the other times I flew to Houston. I don't know the altitude's any difference on international flights. But why didn't I get it when I got back to LA? Because that was from Taipei to LA. So
Yeah.
yeah, I don't know what to think of. Maybe if you have any thoughts on that, but
I had an experience where I was flying, and I think it was just during the descent. So like when the altitude was actually changing, and I got this pain in my sinus that was just like incredible. And so just somewhere pressure was building up and it wasn't able to flow like it was supposed to. When we talk about like bones cracking, like if you go to a chiropractor and they manipulate a joint and it has that audible pop, there's a theory that you're shifting bones, that there's something out of alignment that you're shifting back into alignment. What research is showing is it's just a neurophysiologic effect, and it's just a change in pressure, a gas exchange. And what that does, so a lot of people I manipulate people's backs and they get pain relief from it. It's just kind of like hitting the reset button. And so I don't know if the pressure was in the joint or something else related to your fracture, but I mean, it would be interesting to see, like, if you manipulated your ankle and got a pop, would it change it? I don't know, but that would be, it seems like our bodies create pressure at certain areas, and especially we have really bad awareness of our back. If you look at, it's called our homunculus in our brain, our fingertips and our tongue have these massive areas associated with it where we're sensing the environment, right? So you could pick up a quarter and be able to tell heads or tails, right, between your fingers without looking at it. If you try rubbing a quarter on your back, you might not even be able to tell whether it's a quarter or a dime, right? And so our brain is organized like that. And that's another reason for chronic low back pain, is there's so many structures that could be causing that pain, and we have such a bad awareness of where it could be coming from. And so when we have something painful, our muscles are going to kind of come in and start seizing up and restricting that movement, and then our joints aren't moving, and kind of that pain starts setting in. And if we get a manipulation in there, it kind of relaxes everything. So yesterday with my back, I was trying to lie down, and man, every 30 seconds I realized I was just hiking my shoulder up, and I'd say, okay, relax it. And then 30 seconds, oh, okay, relax it again. And that awareness of what I was doing to guard it and relaxing it is probably why I feel so much better today than I might have if I hadn't done that. That, and, it hurts when I rotate my head to the left. But it was, like to here yesterday, and now, I've just been constantly doing it, going off that severity and irritability. It's not making anything worse, so kind of push into that resistance a little bit, and then as I relax, that muscle that's getting pulled can kind of calm down a little bit.
Yeah. What's the common path when someone contacts you? They do they call you, you talk to them, you do an initial just talk on diagnosis or whatever, then they come in and then there's like an hour diagnosis. What's kind of the common path, and how many times will they see you afterwards? What's the common path?
So typically for me, I have a electronic medical record system. Basically everyone has to have one. And I have my schedule linked to my website. And so when you go for, like, say you're new and you're interested and you haven't talked to me or anything like that, you would go and you could click on the link. It would take you to the schedule. You'd pick a time, and then it would have, this is the cool thing about this EMR, is it has all of the intake stuff on there. So like your medical history, your insurance information, you just plug it into the website, and then I just see that. And so then I can reach back out to you, confirm the appointment time, and then maybe get a little bit deeper into the story so that when I come and see you, we already kind of have that relationship where we're hitting the ground running. Every appointment for me is about an hour, although I try to kind of leave that open to whatever the client needs. And then, we typically, it's all based on you. It's based on your time schedule. If you can only do it once a week, if you can only do it every other week, I can make my recommendation as a therapist. I feel like you need 2 to 3 times a week. Usually it's probably just 2. And then, financial constraints and your schedule and whatever, then we take that and we say, okay, this is how we're going to attack this. Typical physical therapy, you're looking at 3 weeks, 6 weeks, maybe 8 up to 12 weeks for a plan of care. And we set some goals, some physical therapy related goals, and then I go outside the box and say, like, okay, like, what are you really trying to get back to in your life or maintain in your life? And then, if you're interested in being that long-term, having that long-term relationship, then we set those, much further in the future type goals.
Is there people that have insurance and then have, I don't know, if they contact you and then they have to get signed off, by chance is it easier for them to do a cash option first, like just to get a diagnosis and then maybe see if it's a good fit for them, and then they go talk to the doctor about getting signed off, or is that not suggested?
There's really not a reason. I think I've had a couple people that have said, I just want to pay cash, I don't even want to deal with it. But there's not really a reason to say, let's see what insurance is going to do, I guess. One person did have some hesitancy because they hadn't seen the doctor in a long time, and it's like, they don't even need to know about it. In California, like I said, Arizona has direct access, so someone can come and see me and I never have to say anything to the doctor if they're not Medicare. Usually there's still that relationship. So, I almost never did I not have a doctor that I was sending the plan of care to. Out here in California, there's a 12 visit, or I think it's either 30 or 45 days that I can treat someone without having a doctor sign off on the plan of care. So typically I just try to do that right away. And maybe we start seeing them and, okay, we'll figure out the insurance stuff. And, they sign a waiver saying they know that they're financially obligated. So if insurance isn't going to pick it up, then, we have time.
Yeah.
I've been submitting stuff, now that I have a traditional EMR, stuff gets submitted immediately. But I've submitted stuff from like 3 months ago, just all at once, because you got to have time to sit down and fill all that stuff out. So that's interesting.
What is arthritis, and do I have to be in pain?
Yeah, so arthritis is, it's just a word, right? It's really not like broken bone. Like broken bone pretty much equals pain, right? But when we look at arthritis, like we were talking about before, they do studies where people show signs of degeneration or arthritis, and they don't have any pain. And so I've had clients personally that have come in and said, I had all this pain in my right knee. And so they did an image on both, and they're like, are you sure it's not your left knee? Because your left knee is way worse than your right knee, way worse than your right knee. And so when we look at degeneration, we're looking at a whole life span, right? So I equate it like I broke my arm and they did surgery. I have this big scar on my arm right here. Saying that every little nook and cranny of degeneration or arthritis in your spine is basically saying that like this scar should be painful, right? The scar is healed, right? But it's going to look different. It's going to have different qualities because there's scar tissue now. When you're young and you have really smooth vertebrae, the disc on top and the next vertebrae on top of that, maybe you did have a little bit of pain, or it was just kind of like oh, what did I do to my back? Maybe there was nothing, and you were just powering through, and it was just kind of part of living. But when you take a snapshot of that, all you're seeing is what has happened in the past. Unless you have a image of before pain and after pain, you can't see what immediately changed, right? There's some ways of seeing of radiologists to determine a little bit of we know that this is old or this is new. And once if you've had back pain for a long time, you might have a history of other imaging that they can compare it to. And there is a component of arthritis that's genetic. I mean, we all pull stuff from our parents, and that's how we're made up. But a lot of people equate arthritis to, it runs in my family, and so they have those experiences of their parents being in pain because of arthritis, and now the doctor said that I have arthritis, and so now I expect to be in pain too. So that expectation, again, it's a self-fulfilling prophecy at some level. But ultimately, I don't want to take the biological out of it. There are things that cause pain in our body. There's biological tissue issues that cause pain in our body. So I don't want to minimize that. But there's just so many other ways that we can, and the best part is we can do it ourselves, is reframe how we think about that pain to prolong our activity and to not be fearful about movement and living our life.
I guess so for every case of arthritis, it's just, you would have to kind of figure out what, like you just said, you have to figure out what caused it, what did change, and you're a little bit of a detective to figure out how to help them. I mean, you have to kind of investigate why it happened and then what to help fix that, mitigate, and or
right.
Is there, I don't know enough about arthritis, so is there a common, I don't know, is there a common thing that causes it? Which sounds like no.
It's just kind of, you could equate it as wear and tear on your body. Or you could equate it, a lot of some people, I don't quite see the exact match with this one, but you could say it's like wrinkles on your face as you get older. The tissue quality degrades, but
Gotcha.
the wrinkles don't hurt, right?
Mm-hmm.
The scar doesn't hurt.
Is there anything to prevent it? And I'm guessing probably, maybe when you said earlier before, just keep moving. That might be.
Yeah,
a little that you could do.
There's one study that I'm not perfectly familiar with, but the results, they were looking at sedentary individuals, recreational runners, that there was some qualification of how much running and how far you ran to kind of fit into that category, and then like competitive runners that were running just miles and miles and miles. And the group with the least degenerative changes was that middle group, right? So you can't really equate arthritis to wear and tear because that sedentary group was worse than that middle group.
Yeah.
So there's a lot of benefits to weight bearing. There's a lot of benefits to movement, getting that synovial fluid. It's really good for the nutrition of your joints and your joint surfaces. But then obviously, I mean, there's an end to that extreme where you're just putting so much load through those tissues that you have an effect of that.
I find the way that you explain these things, it seems like you seriously are really holistic and you are trying to fix the root of the problem. If someone were to be, say they're in another state and they're not in San Diego, and they are looking for a physical therapy physical therapists, what key indicators would you suggest for them to look for to find a good physical therapist, in your opinion?
Well, I mean, if anyone that's listening to this is interested, even if you live in a different state, I can only, so we have telehealth. So even if you live somewhere else in California, I could still treat you via telehealth.
Oh, awesome.
But if you're outside of California, I have a network of practitioners that is growing exponentially, especially because of COVID, that are mostly mobile, but even if they're not, they're kind of like branching out on their own. And almost every single one of them, it's it's kind of for the same reasons that I'm doing it. They're not, they don't want to work and get burnt out by seeing 4 patients an hour. They want to do better than that. And so if you're interested, you can contact me and I can ask that network to see if anyone's close by. There has to be a person in every state that does it. Whether that state allows for telehealth is up in the air, but we can find answers for you. Looking for residencies or fellowships. So I have, like I said, I'm residency trained. There's a step above that that's fellowship trained. That's a little bit longer process. Just calling and saying asking how many patients an hour are scheduled for that clinic. Word of mouth is huge. So if they know anyone else that's had physical therapy, if you've watched this, you've kind of understood kind of some of the good attributes and kind of some indicators to say like, oh, wait a minute. I thought this was regular physical therapy, but actually I just felt like I was going through the mill. So, I have some questions to ask someone that's been through physical therapy to say like, well, how much time did they spend with you? Did they look at this? Were they doing that? Did you feel like you were attended to every single session? And it might be pretty easy that way. Very rarely does a physical therapist ever, if you work for a company, are you ever going to talk directly to the physical therapist by calling and saying like, hey, I want to interview you to see if I want treatment from you. It's happened a couple times to me when I worked in a facility, but it's usually the front office that's going to be doing that. If the front office is just like, oh yeah, we do physical therapy, come on in, and they don't have any training on what they should be saying to make sure you're a good fit, then call around.
Is there a different title, or so is your company labeled as physical therapy and that's the catch-all, or that's the term, or is there a wellness to it?
Yeah, so I'm still learning the business side of all this stuff. I originally, in California, your sole proprietor name has to include your name and then your actual name. So I started off as Burris Physical Therapy and Wellness. And then I had a couple mentors said like, you shouldn't go by your name, because then if you ever want to, ultimately, if you ever want to sell it, or if you even hire people, they might want to only see you because you're Burris Physical Therapy and Wellness. And so I did a DBA of Life Physiotherapy. And then I just this year incorporated, so I can't be an LLC in California, which is interesting. So I'm a professional corporation starting this year of Life Physiotherapy. So
I feel my stereotype of physical therapy is earlier what you described and what I've been through, the go in, cookie cutter, see somebody for 15 minutes, do what they say for 45 minutes, and then get a checkup once a month. I feel like what you just said, this whole 2 hours of talking, is a holistic view, and I feel it's so different that it almost needs a different name. I hope more of the medical field or the physical therapy field takes on how your angle. Maybe it is. I don't know. The last time I went, it didn't feel that way. Maybe because like you said, insurance is just fucking everything up. Or money, people, greed and money.
You don't, there's not really a good incentive to, I mean, ultimately what would be cool is having something like Kaiser or a big medical thing start having, and maybe they are, having like interprofessional coordination. I've had people that have come to me that have been going to some kind of mental health provider, and I'll start talking about the connections between mental health and pain. And then they'll come back and they say, well, my I don't know what it was, psychologist said, well, okay, you treat your physical pain with physical therapy and you treat your mental pain with when you're here. And it's like, no, like, but we don't get paid to collaborate, right? We get paid by seeing patients. The insurance company isn't paying us to call and talk to all of the other providers that this patient has to find out how we can best work as a team, right? If we all had our own personal doctor, our own personal physical therapist, there could be huge collaboration between us and we could all as a team come up with the best strategy. But that doesn't happen. And so we're kind of at the extreme where everyone, it's just kind of a commodity where, yeah, I go to the physical therapist and okay, yeah, I went to the surgeon. And I think we need to push back against that and say, no, I want my providers to coordinate and collaborate and learn from each other. So yeah, there's a surgeon in, I think in Washington, that he wrote a book and he talked about he talked at a pain conference that I did in Arizona, where he was talking about how he graduated from his school and said, okay, I'm going to be the best surgeon ever. And his surgeries, he said, were mechanically flawless. The fusions that he did and the whatever surgery he did, from a technical perspective, they were fantastic. But his patients were still coming back in pain. And so instead of being ego-driven and saying, well, I did everything that I could, that's on them, he started a program where a patient had to read his book, do physical therapy. They had to promise not to talk about their pain to their family, and they had to do expressive writing. So every day they had to write about their pain, whatever it was, good or bad, and then they had to tear it up and throw it away. And he said that his surgical load dropped like crazy. And even on imaging the patients that he said, like, oh, that's really bad, there's no way that I'm not going to do surgery. Even some of those patients were coming back and saying, you know what, I'm good, I'm better. So, and I've used expressive writing with some clients, and it's been hugely beneficial. Because wow. Again, it forces people to come back inside themselves and be mindful of what they're thinking.
Huh. What is there any? So when you say the mindfulness, what other examples that are either less common or less known? What mindfulness things do you have people practice for pain relief?
Yeah, so one that I commonly use, especially with fibromyalgia, is just doing a body scan. And so always, I mean, incorporating breathing is just kind of a given. If you concentrate on your breathing, good things happen. If you make sure you're taking deep breaths, good things happen. So there's different techniques you can do for breathing. But then after you kind of get them focusing on the air coming in through their nose and filling up their lungs and feeling what that feels in your body, you can, start at the top of your head and just kind of gradually work yourself down your neck. You could go vertebrae by vertebrae if you want. You can go right side, left side, back, front, and then you kind of venture down your arm, and you just kind of take inventory, take stock. Is there pain? Is there tightness? For someone that has like widespread pain, we kind of use a body scan to say, like, do you feel like this spot is causing the root cause of your pain? And then, I'll take them through like a map and I'll say, like, picture yourself, like, out of body experience. You're standing behind your body, like, mark on there where you feel the pain is. Take a marker. You could do colors, you could do temperature, mark on there, or not temperature with that, but you mark on there where the pain is, and then you do some breathing strategies and say, use strategies to see if you can reduce the size of that area. Okay, now go back and draw either inside or outside, or is it the same line? Draw the area that's now painful. And it's crazy that it like shrinks in size. And that kind of goes back to when you have the low back pain, we have such a poor sense of our back that most of the time with pain, you're not saying like the pain is right here and can pinpoint exactly where it is. It's usually like an area because you just can't sense it well enough. And so having that that mindfulness on the low back of like how big is that radius of the pain seems to work really well. And then temperature works well. Does it feel like a hot dagger? Okay, picture yourself removing the hot dagger, putting something cool, a cold pack or something, splash it with water like you're putting out a fire. Using some techniques like that can be beneficial.
Awesome. What habits do you have? I thought I used to have this question as what daily habits. What daily habits do you have that greatly impact your life?
Well, habits is huge. That's kind of the mindful, intentional living that I've focused on these last few years, and realizing that, especially when you have a job or you're busy with a job and kids and I used to coach basketball and my days were just filled with a lot. And life just kind of happened to me. And so just going back to the mindfulness, establishing that precedent that, it could be in the shower. It doesn't have to be laying down super quiet. It's just a time you could be driving where you kind of just take stock of what you're grateful for, take stock of what's happening that's good in your life, what could be better, and making sure that that's a focus. Physical health obviously is a big one. And maintaining those habits are hard. I thought, after physical therapy school, I'd be like, go to the gym every day and I'd have all the motivation in the world to maintain my physical activity. But that's been, life happens and habits come and go. But my wife and I have found good habit formation and maintenance with like home-based workout programs. So that's kind of what we do.
Awesome. Okay, so we talked about this a little bit over email, but go ahead and answer how you would like. What do you know about about Vietnamese culture?
Not a lot. My father-in-law went to Vietnam, I believe, when he was in the military. No, he went when he was in a golf program at Arizona State, and one of his projects took him to Vietnam because he brought me back a Vietnamese hat. So I knew him, and I didn't know him in the military. So, not a ton.
Yeah. The title of this channel is Some Viet. I wanted to do. I don't know if people get it, and it doesn't really matter that much. I do like in the logo it says Vietnamese culture, food, and something. And then the tagline, it says by some Vietnamese person. And I was born in America. I'm pretty much all Vietnamese. I'm like an eighth Chinese, but all I know is Vietnamese culture, as in we're not being raised by two Vietnamese parents. So I don't know if I'm going to change my channel to like the Lim Lee podcast or what. I like the idea of just asking people what they know about Vietnamese, more so that I think this platform is also people sharing their stories. So then I could also just share my little bit of Vietnamese.
Right.
So I don't know if I'll keep the name Some Viet. I do worry if people if they see the name and they think the logo is just Vietnamese and they think that, oh, this podcast is just going to be about Vietnamese, and it's
Right.
not. Obviously, we spoke this entire time, and this is the first time I brought up anything Vietnamese. So,
Right.
have you had any Vietnamese food at all?
I think that I've had pho in Arizona.
Okay. Yeah, pho's the staple Vietnamese dish that everyone knows about. It's an amazing beefy soup that takes like 6 hours for the bones and everything to get into the broth, the meat and the bones. Yeah, I think most people that don't know, or most Americans that look at if you try to say PHO and you try to say that, most people will say pho,
Right.
but that's common. The other the thing about Vietnamese cuisine, if you get a chance to try other dishes, I would probably suggest try there's a rice and grilled pork dish that's basically the pork. They do marinate it with fish sauce or cook it with fish sauce. So depending on your tolerance with that. But I would say if without knowing that, if you ate it without knowing it, it doesn't taste like fish sauce. It's just a super beefy cut of pork, as in the flavor is very beefy. Like when you cook fish sauce into something, you get more of just a meaty flavor, not a fishy flavor. There usually is a side of fish sauce that's sweet, salty, and spicy that you usually cover the pork and the rice with. But if people don't like fish sauce, you don't have to use that. But I highly suggest try that dish sometime if you get a chance.
Right.
It's delicious. It's the pork itself is kind of like a sweet and salty, so kind of like a teriyaki flavor.
Okay. Is that called something specific?
Oh, it's gum tet nung. Gum tet nung. Gum is rice. Tet nung is grilled pork. On the menu, you may see it as broken. It might be titled as broken rice grilled pork. Broken rice is just the grain. I think they break the grain because it brings out flavor. To me, it tastes like normal rice. I kind of can't. I can't tell the difference with broken rice or regular rice. So, yeah, look for either rice or broken rice grilled pork.
Okay.
What do you know and or think of cryptocurrency?
Oh man, I know that I bought some. I know that it is very private. I know that if you lose your key, you're done for. I have to find a key for one of mine.
Oh no, find it. Okay.
All right, yeah, for some, I have it, but for some reason when I try to log in, it's not letting me. So I have to figure that out at some point. Yeah, that's about it.
Okay. Do you know much about or what do you know about blockchain?
Not less than crypto.
Okay. Okay. So cryptocurrency is what's an analogy? I can't think of one. So blockchain is the technology underneath. It is the consensus module for like a mining server, and a bunch of mining servers to say, hey, the transaction came through. I'm going to mathematically do my algorithm to see if that account A has enough funds to send to account B. That mining server will say, yeah, that looks right. And if it's the first one, it'll broadcast it out. And the other mining servers will say, yeah, that looks good. So then this builds a blockchain that they all agree on. If something comes in that's faulty or incorrect, like some accounts trying to send 100 coins and it doesn't have 100 coins, then one mining server will just kick it out and it won't include it into that next batch of transactions. So the batches of transactions that are agreed upon by the majority. Earlier when you asked about my suggestions on like Bitcoin, Ethereum, my allocation is about, I think I'm 90% Ethereum, 5% Bitcoin, and then 5% others. I think Ethereum, I'm not a financial advisor. I'm a stupid dumb shit and I might be wrong, but my horse is, I'm pretty harsh on myself, huh? My bet on the horse is Ethereum. I think that's the long bet. I think right now, if I had to put $100 on one single cryptocurrency to guess that it's going to be the biggest cryptocurrency in the long run, it would be Ethereum.
Okay.
But as innovation, as culture, humans, it's hard to guess what humans are going to pick. And sometimes they don't even pick the best one. That's the nature of humans. So I think Ethereum has a super bright future. And right now, if I had to guess, I think Ethereum will take over Bitcoin and will eventually become the biggest cryptocurrency. Now, that's my current guess. Maybe some other cryptocurrency will come out and be better than Ethereum. The reason why I think Ethereum is the best one is, so I define cryptocurrencies in my own definition of a blockchain 1.0, 2.0, and then 2.1. Blockchain 1.0 I define as Bitcoin. Bitcoin was it was fantastic. Satoshi Nakamoto, that we don't know who he is, fucking genius to put this consensus module and put the RSA encryption to make these mining servers be able to say, here's my signature with this RSA encryption. I approve this transaction and I think it's the correct one. And then another server says, yep, I might be messing this up. With the RSA encryption, that other server can validate and know that that other server was the one, and they can approve it with that encryption, with that RSA encryption. So Bitcoin was blockchain 1.0. That was just simply that mechanism. All it is a way to validate transactions, and it was genius, but that was 1.0. 2.0 is what I describe as, let's add a programming layer on top of that. So let's take that 1.0 and keep that, but let's add a programming layer where Ethereum is able to do smart contracts. So with that programming layer, you could build logic that says, let's say we have a smart contract between me and your physical therapy practice. Is it practice or company? I'll say company for the heck of it. Say the smart contract we agree on, I'm gonna pay 25% of the fees up front for me and you, for me to have an hour with you. And then when you sign off from your Ethereum wallet, you could sign that contract that me and you made. When you're done with your services, you sign from your wallet to say that you finished the services, and you get another 50%. So that's a total of 75% of that smart contract, the amount that we've agreed to. Let's just say, I don't know, say $1,000. Say $1,000 for whatever. That'd be an expensive 1 hour, but whatever. You got $250 when I sign the thing. You get another $500 when you sign off. And then the final part, I could say, yes, that was a good service. I'll sign off and say that you did a good job, or you at least did the job that you agreed upon. You get the total next 25%, which makes 100%. So this smart contract is innately built into Ethereum. It was thought of since the conception of Ethereum to have that programming layer. Okay. So we could have the smart contract. So that smart contract is programmable, meaning it could basically do anything that we program it to do. So that could be one smart contract for that. We could do a smart contract for like Uber driver, Uber the company, where they allocate the client to pay Uber sends the money back out to the Uber driver.
Right.
So I consider that blockchain 2.0. I consider, this is my definition of 2.1, is trying to make blockchain fit for humans, where it's faster and maybe it thinks about the energy it's so Bitcoin right now, it's like, I think Bitcoin itself, the network of the, I don't know how many millions of servers, whatever millions of servers, is taking up the same electricity as Ireland supposedly every day. So that's a massive tax on our planet per se, or planet and or humans, because it's electricity that someone's paying for, servers, hardware. So blockchain 2.1, I think, is going to try to address that. But when you give up security for speed, that there's a balancing act to do there. And that's where Ethereum actually has Ethereum 2.0 in phase, is it phase 0 right now? So they're going to try to transition Ethereum 2.0, and actually it'll end up being seamless to the end user, but Ethereum 1.0 will evolve into 2.0, and it will change its mechanisms on how the mining servers work to take up less electricity and be a lot faster. So that's where my horse is. I think that's why it's the future. I know there's other cryptocurrency out there that are trying to do what Ethereum 2.0, and they've actually might have even started earlier, but I don't think there's been a cryptocurrency that has gotten close to it, in my opinion. Or I think there was one that got close, but that is looking bad for them. They have some, either just the development, the road for them has been bumpy. So I'm not going to suggest that other cryptocurrency right now. So yeah. So if you ask me what cryptocurrency I suggest, I think Ethereum is it. I don't think that cryptocurrency will go fully towards a private evolution, meaning, so there's Monero, there's, what's the other one? There's privacy cryptocurrency coins that strictly, their whole algorithm is just about privacy. Like, if you send from your wallet to somebody else, like, nobody could really see it. Just for all they see is some wallet sent something to another wallet, 5 coins. That's all anyone sees. And they can't even see the history of your wallet too. Like, if you sent out 5 here, 100 there, nobody could even see that. It seems pretty, I don't see a future for in everyday human use. Maybe I'm wrong. I just don't see a reason why we need to be so private with that. But maybe you could say if someone wants to play devil advocate, well, on Ethereum, if you know someone's wallet, you could see their whole history.
Right.
But you see a whole history, but you don't know who they sent it to. Like, maybe if you see, like, say Chase Bank if Chase Bank were to have a wallet, and you saw this person keeps on having, like a $1,500 paycheck every month, whatever it is, into their Chase account, maybe you could see that. But if they sent it to their cousin, you wouldn't know that wallet. You would know the Chase Bank. You would know the Chase Bank wallet because it's a well-known wallet.
Right.
So yeah, I think that's good enough on the Ethereum or those cryptocurrencies that are not so focused on privacy.
Yeah.
Do you happen to have any questions on cryptocurrency in general?
No, well, you explained it more in depth than I've ever been able to comprehend before. So
Yeah.
nice. I think it was Ethereum that a friend suggested we start mining for back a few years ago when it was starting to spike. So we were talking about the energy consumption and all that kind of stuff, and then really, like, right before we pulled the trigger, it shot back down. So we dropped that.
Yeah. For people that are current, at least this is just my suggestion, and I'll say this is my history, that when I've been involved with cryptocurrency, I do mine and I do buy coin. I've actually bought and mined at the same time, and it was really interesting to see the profit from either one. And it's always been actually buying direct coin was a better value than mining.
Oh, really?
Yeah. That it's weird where even people that understand this concept of mining and buying directly, I'll tell them like, yes, my buying coin has flourished like 500%, 600, about 600% more than buying coin or than mining. And it's funny that I say that and they still, no, I want to mine because then you have hardware. If you need to just sell your hardware, you could sell your hardware. I'm like, dude, 600%, dude, that's already, when you're talking about if cryptocurrency's gone up 600% times 600%. So you're losing so much value by mining. Now,
Right.
mining, I like to be a part of the network. And actually the other thing about mining for me was to understand it better, to just get in and I want to understand this. And what maybe one major point to add that is this whole mining thing and the way that it's a global decentralized system. I do think it's the future because the genie's out of the bottle. I don't think there's going to ever be a time that the whole world gets EMP'd and every server gets blown up.
Right.
I just don't think that's going to happen. So that means cryptocurrency is here to stay. You cannot kill it. You can't fully regulate it. You could try to regulate people. If the US government says, hey, fuck cryptocurrency, it's going to flourish elsewhere. And this technology is so innovative. This is where I may go beyond what realistically may happen. I might be too optimistic about cryptocurrency, but this blockchain thing is such a beautiful set of code that it provides something that we've never seen. Humans have never ever been able to have before is consensus of truth. What that does is that allows so many powerful things. You could truly have third party, like say a third party adjuster for an insurance company. You could actually have a blockchain that's built around insurance companies and third party adjusters where I want a third party, if I get in a car accident, I want a third party to say how much of the value of the car, how much of the damage of me, and I want this third party to be unbiased. I don't want them to be biased. Most of the times you get the insurance company that has an adjuster to come out. No, that's wrong. That's fucking, they're for the insurance company. So in a blockchain cryptocurrency world, you could actually have on the blockchain third-party adjusters and everyone votes. Like after I have a insurance claim, I could vote, oh, that adjuster, they're 75% too much on the insurance side. And if you get everyone voting on this, eventually you're going to get someone that's 50-50 and everybody's going to start wanting picking these people that are 50% bias on either side. It'd be a fantastic world where we could cut out like lawyers with smart contracts, and you could have true third-party adjusters that are 50-50.
Yeah.
So this is a paradigm shift. That's where I think that this could go. It's a great tool, but humans are pretty fucked up sometimes, and the masses, they're fucked up. So maybe blockchain and cryptocurrency may not go, but the genie's already out of the bottle and you can't turn this off. So I think it's going to be baby steps to get there.
Right.
Are we 10 years out, 15 years out, 20 years out, 50 years out? I want to guess we're less than 20 years out. So, and I do think, and some people will say, is it cryptocurrency? Meaning, is that going to be the one? Why don't we just use blockchain? You have to have cryptocurrency because you have to have a trusted network. And the only way to have a trusted network is to pay all the miners their little fees to keep it a decentralized, trusted place.
Gotcha.
Proof of stake, I won't. That gets more complicated. There's another way of mining with proof of stake, proof of work. Let's not get into that. So, anyways, yeah, I do think cryptocurrency is the future. Yes, I do realize that I'm pretty optimistic about it, but I think I make some very valid points on how this could impact the world.
Yeah. Very cool.
Maybe a common question would be, what should somebody do if they're asking about should they get involved in cryptocurrency? I would suggest for people that have money that they can invest. So I would, investment money is money that you could throw away, whether 401k, and even when I put money in 401k, I think of it as it could possibly go to zero. Unlikely, but it could. And I try to think, so that's how I think of cryptocurrency right now, because the future is unsure. Nobody can predict how it's going to play out. But I think it's with its potential of still, even at this point, when people look at Bitcoin, they're like, oh, 35,000 a coin, that's so much. And then I would rebuttal and say, well, we probably have less than 0.01%, 0.01% of people, maybe even less, 0.01% of people have put money into cryptocurrency. So the ceiling could go up really, really high. So then if they think it's too late to get in, I say no. And then what would I suggest? Any money that you could throw away, throw into it. I think I've heard some people try to say do a 90-10, 10% in cryptocurrency, 90% into your 401k. That one probably seems a bit aggressive, though. A conservative person, I would suggest maybe go 2 to 5%, then the other percent into your 401k type of thing. But as someone that I like cryptocurrency so much, I would try to push for the 10% if you can, if you could afford it, because I think it's going to blow up. I think cryptocurrency it has such a high ceiling.
Cool.
All right. Okay. What do you think is the biggest problem nationally or globally, and what should humans do to fix it?
Oh man, I think probably globally has got to be climate change, and I think unfortunately it's been politicized for a long time, because there are a lot of people that stand to lose if we move towards sustainable energy. I'm doing my part. We're getting solar. We're in the process of getting solar. I think it's got to be those micro changes at the person level, and it's got to be policy changes.
I think policy is actually pretty big. The amount when you hear some stories, like it could actually hear even in America, where you'll hear fracking oil and how devastating that is to that patch of land there and the community that it impacts. That seems like, that seems so bad. Why haven't regulations come out to help that situation or something?
I read, and most people are going to say she's crazy liberal, but Rachel Maddow had a book called, I think it was like Blowout or something, but it kind of detailed the oil and gas monopoly, and then specifically went into fracking, I think in Oklahoma, and just how much was being covered up, how much of like the increase in earthquakes and just crazy stuff that you think, oh no, this couldn't happen. And it actually tied into the Oklahoma City Thunder, moving the supersonics to Oklahoma City. That was all done by big natural gas people, and a couple people have just made so much money off fracking, so there's just there's always going to be money won and lost to get energy, because we're not going to stop using energy, but like with mobile therapy, I have a hybrid Highlander right now, but I'm on the list for a Cybertruck. We'll see where the
awesome
goes by the time it comes out. But we're overestimating on the energy usage, so that if we do get an electric vehicle, it'll cover that as well. But just doing every little bit we can, and then I don't know.
I probably the best argument for electric cars for a while, I didn't understand the economy of it, I used to think, well, electricity comes from the wall, electricity comes from a power plant, that power plant's using coal. So isn't electric cars the same shit? And then someone said simply that the power plant is able to do something about 70% where if they burn coal, the heat that's generated, they're also able to capture the heat and reuse the heat too. So they're just so much more efficient than what we could do with gasoline in our car.
Right.
So they were saying, so that's basically the 70% gains. So yes, it is using coal, but you're using potentially 70% less.
Right. But then if we have the resources to have solar on everyone's rooftops, and that's providing all of the energy for that house, then all right, we're doing fantastic. But SDG&E's got to make their profits, and
oh, dude, it's so corrupt. Here in I'm imagining a lot of other places are like this, but here in Nevada, NV Energy, the electric company, they have like a monopoly where they have to. I don't fully understand it, but to put solar power up, you have to agree to not, I forget what the number was, like 70, you can't use more than 75% of all your electricity from solar power. I'm like, how the fuck do you dictate that shit? What the fuck? This is a dirty monopoly.
Oh, it's crazy.
And that maybe I have that slightly wrong, but that's what I remember reading on the contract. How could they have so much power to still say, oh, you still have to buy 25% electricity from your wall right. from NV Energy?
Right.
Oh man.
Yeah, it's crazy.
And last question. Think of at least one person that you know personally that should do this conversation with me. Call them out. And you could say first name if you want.
Oh.
Any person that has interesting stories, interesting career. And they don't have to know me.
I should have known this was coming because Dennis
called you out.
Yeah, and you got Evan on there too.
Yeah. And actually on top of it, it doesn't have to be someone that has a spectacular story too. Like even a friend that just seems to be passionate about their career.
Be passionate about their career.
Yeah. Because I find that someone that's passionate about their career, they end up having a lot of stories.
Yeah, I mean, I know some physical therapists that could do it for sure. Mm-hmm. Yeah, I'm gonna say Kyle.
Okay. Okay.
He's my mentor, physical therapist.
Awesome. Okay. Awesome. I'll get we'll figure it out later. I like as in how to contact him and whatnot, but we'll figure that out later.
Cool.
All right. I think we're done. Is there any closing thoughts? Anything you want to say? We could cut this out too.
No, I appreciate I appreciate you giving the platform to come and talk. I know, I don't know if this gets backlinked or I don't know how all that stuff works, but I know it's good to get your name out there and stuff like that. But more than that, there's so many people that are shocked by what I talked about. But normally it's just one person that I'm talking to in front of me, one client at a time. And there's certainly, I don't know everything. I don't even know a fraction of what I need to for insurance stuff. But I realize that the system is failing people. And so, however, I have opinions that another physical therapist would differ from, physicians would differ from, surgeons would differ from. But I think the conversations need to be had, and the public needs to be more aware of their choices and how much control they have and can have.
Yeah, that really connects with when I went through the broken ankle incident, all that. Oftentimes I'll tell friends, if you can, have a very good friend by your side during all that. Someone that can make executive decisions for you that you trust beforehand. Because when I was doped up on OxyContin, I mean, to think about stem cells or how to do, is this physical therapy the right thing? And you can't navigate that under all those drugs. And even when you're, even if it wasn't for the drugs, I'm just thinking about trying to walk. I'm thinking about how much pain in the ankle. Like, I wish, I wish I knew to just ask friends more, just like, hey, I'm thinking about this. Can you think outside of the box for me on all this holistically?
Right.
And I think having these conversations, I think, brings up those ideas.
Yeah. Kind of that whole thing was all encompassing of mental health, but I think that mental health should be considered like physical health, right? It shouldn't be, and this is where diagnoses come in. Like, mental health should be talked about as much as physical health. Like, there's no reason why we shouldn't be talking about and promoting mindfulness to have someone be so in control of themselves. But I think that probably capitalism kind of puts a damper on that, right? Because if you're mindful of your purchasing and you're mindful of what you actually need in life, you actually don't need a whole lot, right? And so mental health has such a stigma attached to it. I want to collaborate with mental health professionals and try to increase people's access to them, or decrease the barriers that they feel like there's something wrong with them, that they should be seeking mental health, right? Like, if there's something wrong with your shoulder, you say there's something wrong with my shoulder. It's not something wrong with me, it's something wrong with my shoulder. But with mental health, you have to say there's something wrong with me right now. And I think just kind of like changing that to, I just need some guidance right now, right? It would be so much more powerful.
I think that's huge. Did you happen to see one of my conversations with Trin? She's with NAMI and National Alliance of Mental Illness, and that's interesting that you say that physical therapy and mental illness should be kind of somehow should work together.
Coordinated.
Yeah, coordinated. Yeah. On the NAMI thing, they're a non-profit and free for participants, so fully free. It's just if they have an issue, they show up and go to the group meetings and talk it out and get help from others that have the same experience.
Nice.
So maybe if you contact the San Diego chapter and see if there's a way to kind of tie that in.
Right now.
Yeah. NAMI as in NAMI.
Yeah. Okay. I'm calling them today.
Thank you. Wow. That's awesome, man. Yeah.
Can I change my my person?
Change your person.
Yeah.
Oh, yeah.
Let's go with, do you remember Jeff?
Jeff? No, I don't.
He is in Las Vegas, and he's the photographer for UFC.
Oh, wow. Okay. That'd be awesome. Yeah, I'm in Vegas right now, so that'd be pretty cool. We could actually do it in person, maybe.
All right. I'll see if he's interested. He's not I don't think he's kind of looking to promote anything, so it he might be hard to get a hold of, but I think it would be an interesting conversation for sure.
Yeah, awesome. Yeah. Thank you so much for your time.
Yeah, no problem. Thanks for having me.
Dr. Burris, you've shed so much light, I think, on this topic that I had no idea actually going into this. I didn't think that there would be so much light to be shed.